Hello everyone, good day. I'm Marigold Andoyo. In this video, we will talk about the acquired coagulopathies. We begin with the acquired coagulopathies because more patients experience acquired bleeding disorders secondary to trauma, drug exposure, or disease than possess inherited coagulopathies. Chronic disorders commonly associated with bleeding are liver disease, vitamin K deficiency, and renal failure. In all cases, laboratory test results are necessary to confirm the diagnosis and guide the management of acquired hemorrhagic events. Acquired coagulopathies, we have trauma-induced coagulopathy, liver disease coagulopathy, chronic renal failure and hemorrhage, vitamin K deficiency and hemorrhage, auto anti-factor 7 inhibitor, and acquired hemophilia, acquired von Willebrand disease, and disseminated intravascular coagulation. In trauma-induced coagulopathy, we have massive transfusion, plasma, platelet concentrate, trauma-induced concentrates, and monitoring therapy. So the trauma-induced coagulopathy, or TIC, accounts for most instances of fatal hemorrhage and 3,000 to 4,000 hemorrhage-related deaths can be prevented through coagulopathy management. TIC is triggered by the combination of injury-related acute inflammation, hyperthermia, acidosis, hypoperfusion, or distribution of blood tissue associated with low blood pressure, all, all of which are elements of systemic shock. Systemic shock leads to acute reduction of Adams 13. So Adams 13, meaning a disintegrin and metalloproteinase with a thrombospondin type 1 motif number 13, or aka von Willebrand factor cleaving protease, secreted by the liver. In coagulopathy, massive transfusion. Trauma centers publish and maintain massive transfusion protocols for management. Massive hemorrhages defined as blood loss exceeding total blood volume within 24 hours, loss of 50% of blood volume within a 30 or 3 hours period, blood loss exceeding 150 ml per minute, or blood loss that necessitates plasma and platelet transfusion. Trauma-induced coagulopathy, plasma. Plasma is a key TIC management of component donor services. Separate and freeze plasma within 24 hours of collection, officially naming the product FP24. In platelet concentrate inventories are limited and costly to manage, but concentrate contributes to positive outcome because platelet can help microvascular bleeding. Platelet concentrate therapy is generally effective when the patient has immune thrombocytopenia, thrombotic thrombocytopenic purpura, or heparin-induced thrombocytopenia. In liver disease coagulopathy, we have coagulant deficiency abnormalities and liver disease disseminated and in liver disease, hemostasis laboratory test and liver disease, hemostatic treatment to resolve liver disease-related hemorrhage. Liver disease may be functional failures or anatomic and large disease or esophageal disease are complication of chronic alcoholic disease, hemorrhagic thrombolysis, varices, catalyzed bleeding, not coagulopathy. So often fetal mucocutaneous bleeding occurs in liver disease associated thrombocytopenia, often accompanied by decreased platelet function, anatomic bleeding is a consequence of procoagulant dysfunction and deficiency. Procoagulant deficiency in liver disease. The liver produces nearly all the plasma coagulation factors and regulatory proteins, hepatitis, cirrhosis, obstructive jaundice, cancer, poisoning, and congenital disorder of bilirubin. Metabolism may suppress the biosynthetic function of hepatocytes, reducing either the concentration or activities of the plasma coagulation factors to less than hemostatic level. Platelet abnormalities and liver disease. Moderate thrombocytopenia occurs in one-third of patients with a liver disease. Platelet counts of less than 150,000 ml may result from sequestration, important infant survival associated with portal hypertension and resultant hepatosplenomegaly. Associated with vascular coagulation and liver disease. Chronic or compensated VSC is a significant complication of liver disease that is caused by facility with the production of regulatory antithrombin, protein C or protein S, in and by the release of activated procoagulant from generating liver disease. In instances, laboratory tests, the PTT fibrinogen concentration, platelet counts, and dimer concentration are used to characterize the hemostatic abnormalities in liver disease. Factor V and Factor VII assays may be used in combination to differentiate liver disease from vitamin K deficiency. We have also inventories of liver disease-related knowledge. So in chronic renal failure and hemorrhage, chronic renal failure of kidney cones is often associated with platelet dysfunction and mild to moderate cutaneous bleeding, platelet admission to blood vessels, and platelet aggregation are suppressed, perhaps because guanidinosinonic acid or phenolic compounds coat the platelets. In nephrotic syndrome and hemorrhage, is a state of increased glomerular permeability associated with a variety of conditions such as cholelithitis, elevated glomerulonephrosis, systemic lupus erythematosus, amyloidosis, and renal thrombosis. We have also vitamin K deficiency in hemorrhage. This part we will talk about hemorrhagic disease of the newborn caused by vitamin K deficiency. Vitamin K antagonist and detection of vitamin deficiency are big factors. In vitamin K required for normal function of the vitamin K dependent upon the improved coagulation factors is the key foods include especially green vegetables and green farmers. A small salty water deficiency is when the body stores over and become exhausted. So the usual diet is interrupt as when patients are fed only with a parenteral nutrition for an extended period or when people embark upon fat diets. Hemorrhagic disease of the newborn caused by the vitamin K deficiency. The newborn was common in the United States before routine administration vitamin K to infants was legislated in the 1960s and it still occurs in developing countries. Vitamin K antagonist chromatin. The gamma carboxylation cycle of coagulation factors is interrupted by the coumarin type oral anticoagulants such as warfarin that disrupt the vitamin K peptide reductase and vitamin K quinone reductase reaction. Thus, the detection of vitamin K deficiency or physical factors, a prolonged PT with or without prolonged PTT supports the clinical suspicion of vitamin K deficiency. The autoanti-factors 7 inhibitor in acquired hemophilia. We also we also have blood-based assay to detect acquired hemophilia factor inhibitors other than autoanti-factor 8 acquired hemophilia management. Autoanti- hemophilia 2 to 5 months after the delivery. We also have acquired von Willebrand disease. Acquired von Willebrand factor deficiency. This is symptoms similar to those congenital von Willebrand disease has been described in hypothyroidism, benign monoclonal gammopathies, Wilms tumor, intestinal dysplasia, congenital heart disease, pesticides exposure, lupus erythematosus, and autoimmune proliferative and proliferative disorder. The pathogenesis of acquired von Willebrand disease may involve decreased von Willebrand factor production, absorb of von Willebrand factor to abnormal cell surfaces as seen in sorry, associated with lymphoproliferative disorders and Wilms tumor or in less than 2% of cases a specific von Willebrand factor antibody. Disseminated intravascular coagulation, VOC, although characteristically identified through its hemorrhagic symptoms, is classified as the thrombotic disorders in is described in chapter 39. That's all for today. Thank you so much.